So we move on from single cases to case series. And for the question about the link with public health and what actions we take, you can see that we have individual case safety reports, and then we go to case series and looking what further information is there when you put series cases together instead of alone. And then we look with Pia at, does this confirm a signal? And if it does, what action do we take? So that's the plan. So we're at this level here. So we're aiming to answer the following questions. Did the drug cause this adverse reaction? Does it increase the risk of this adverse reaction occurring? And if it does, how can we decrease the occurrence of it? So for this presentation, a case series is defined as a group of patients with similar exposure, the drug, and similar outcome, the suspected adverse reaction. There are problems with single case causality criteria. For example, with Naranjo, is it a known event? Not good for detecting new signals. Plausible timing after the drug was taken, yes, but sometimes we don't know what the plausible timing should be. But if we put case reports together, we might see a pattern of a time to onset. We might not have had D or re-challenge, as we discussed. Excluding other causes, there may be a number of causes for one adverse reaction, and we might build up a better picture with more cases. And typical adverse reactions are good, but there's only a small list of these. So assessing a case series might supply additional information that's missing in individual reports. We still apply a logical analysis, but it's a little bit different from the individual case assessments. But you do need to do the individual case assessments as well. And then statistical disproportionality methods highlight case series for clinical assessment. So if you have a signal because you've run a statistical program across your database, you still need to do this clinical assessment we're going to describe now to be sure that there is or is not a signal. So what guidelines do we have? Well, first of all, we consider what each report tells us about the patient, just as we did for single case reports. What does it tell us about the patient, their age, their gender, their background disorders? What does it tell us about the drug and the concomitant drugs and the other suspect drugs? And when we talk about drugs, we mean medicines and vaccines. And what does it tell us about the adverse reaction? What other, there was perhaps one adverse reaction term, what other terms were reported with it, and how intense it was, and so on. And then we need to think about outcome, including D-challenge and re-challenge, and of course it's important to know how serious it was. But then we have some criteria we can apply, and these are all due to this gentleman, Sir Austin Bradford Hill. And he was probably one of the first real medical statisticians. He worked with clinical trials of tuberculosis drugs, and he also worked with Sir Richard Dole on trials to assess if smoking or petrol fumes, in fact, they were assessing if people in cities or urban areas had different levels of lung cancer. In fact, they recorded smoking and found that the strong association was with smoking. Of course, there was a huge outcry, and Sir Austin Bradford Hill gradually developed these criteria to help decide whether there was likely to be a causal relationship between an exposure and an event. And he was so good at it, the Queen of England took a sword to him, but she didn't chop off his head, she laid it on his shoulder and knighted him. And recently, our colleagues, and we gave these to you in the pre-reading, have said, actually, although Sir Austin Bradford Hill was talking about case control studies, epidemiological studies, and even clinical trials, if you apply these criteria to a case series, we can get very similar benefit from using them. And so we've started to apply these criteria to case series. Now, just like the other criteria, you're not going to get yes, you don't expect to get yes to every one, and you won't always have the information, but they're a guide. And so if we start with them, some of them were strength of association, how specific the event was, time relationship from starting the drug to onset, dose response, consistency of reporting. So let's go through each one. And that's, well, I should have said that before. Anyway, you can see that. So when you've got some disproportionality measures or relative risks and your observed number of observations is greater than expected, if that's statistically prominent, and especially if it's strongly so, then that's a bit of evidence. But as I said before, if it's a statistical strength of association, you still need to look at the reports clinically. And then we talk about the time to onset, the reasonable time to onset. But we have a problem that we don't always know what that should be. And as I said, you might just see a consistency across the reports if you have something where you don't know and it's new. But there was a study done at the UMC by Ghazalia Kodabakshi, and she looked at this number of reports of these serious disorders that are often drug-related, agranulocytosis, angioedema, hepatitis, serum sickness, SJS, TEN, that we've discussed. And what she found was that if you develop agranulocytosis, it's normally in a week or two after you start the medicine, whereas angioedema is very abrupt, usually very abrupt, like anaphylaxis. Hepatitis takes a little bit longer, as does serum sickness. Stevens-Johnson syndrome, toxic epidermal necrolysis can be in the first few days, but largely a little bit later. So you start to see a pattern. But we don't always know what it is, and then we look for consistency. And consistency was one of the criteria. So sometimes you get one person in one country who sees something and says, I think that's a drug reaction. And every time he sees that event, he looks if the patient's taken the drug and he reports it to you, but no one else does. And he might be right, or he might just have a bee in his bonnet. So you have to look at the reports very carefully. If the reports come from a range of reporters within your country, or in Vigibase, they've come from a range of countries with similar observations in the reports, then that's called consistency. Biologic plausibility, it fits with what we know about the drug's actions. We've talked about that before. We don't always know that it fits because we don't know why the reaction, what the pathology was behind the suspected reaction. But if it does fit, then it's evidence. And for example, we know that anticholinergic drugs may cause urinary retention because the bladder outlet sphincter can't relax. It's most likely to occur if the bladder outlet's already compromised, for example, with an enlarged prostate. If a new drug is reported to cause urinary retention, then if it has some anticholinergic activity, then that is biologically plausible. Sorry, I should put theoretically, I mean biologically. So that's one example. We then talk about coherence. Does it fit with existing knowledge? Look for patterns in. So, for example, we know that furosemide can cause loss of potassium. If it's not working very well, it might not affect the potassium level at all. But the way it acts means that it can't retain potassium. So if you have a report of furosemide and high potassium levels, it's highly likely that another medicine is being taken or the patient that causes it, like spironolactone, or the patient has gone into renal failure, and it's very unlikely to be the furosemide. And we can also, for coherence, look at patterns in reports. Is there a similar duration to onset? Is there a similar dose? Is there a similar, maybe an interaction is a pattern you see that's often prescribed with one other medicine, and is there an interaction? And then we look at the dose-response relationship. That's self-evident. Again, especially with those type B immunological type reactions, you might not see the dose response. There might be one, but it's way below the dose you use to treat the patient. But if you do see it, it's evidence. And then for specificity, We've talked before about people presenting with headache or abdominal pain, or yesterday we talked about people presenting with renal failure, that these things have very many causes. And so it's a bit difficult to say you have a signal for a headache or abdominal pain or even renal failure if you don't know what's causing it, what the underlying pathology is. But if you have some benign intracranial hypertension or intestinal obstruction or interstitial nephritis or renal stones causing renal failure, then that's a specific adverse reaction. And also, you look for specificity in the drugs. Have you got a whole list of drugs that are suspect or just one or two? It's more likely to be a real association if there are just one or two. Experimental evidence. Sometimes people have shown that an adverse reaction is possible because of the work they've done previously on animals or humans. For example, many drugs now are checked for prolonged QT interval, and you might find that the studies showed that there was a small effect, and then you find some reports in patients where it was more severe, but you've got some experimental evidence that it does occur. And then we talk about analogy, and this is similar reactions observed with other members of the drugs ATC group. So we know, we gradually develop the knowledge that combined oral contraceptives that contain estrogen can all cause venous thrombosis, and that fluoroquinolone antibiotics, all of them can cause tendinitis, although we only saw it with ciprofloxacin to start with. Now, in your folders in the middle of the table, the green ones, you have the WHO criteria and the Narendra criteria. You also have the Bradford Hill criteria so that you can be reminded of this as you're doing your work. Now, it all sounds a bit theoretical, so let's remember we're doing this to detect signals in order to minimize harm to patients. Let's keep that in our mind. It's not just an intellectual exercise. And when we do have a signal, it can be published and sent round from the UMC to the national centres. And then the national centres can think about whether they have similar reports that are not yet in the database, and we can build up the knowledge. I'll just run through an example. I went back to our early reports in New Zealand. We were not the people that found the signal of omeprazole and renal problems. But I looked at what our database looked like right at the beginning. In 1996, if we had been looking for if we'd been screening, the very most simple way of screening is to say, let's look at reports when we have 3 of these reports for the first time. And there were 3 reports of omeprazole and acute renal failure, reported since 1994, so for 2 years. 2 males, 1 female, aged 67 to 78 years. Omeprazole was the sole suspect in all the reports. 1 patient died. They had rheumatoid arthritis, and it was thought they might have had rheumatoid vasculitis affecting the kidneys, but there was no evidence for that. 1 other patient hadn't yet recovered. The other, it was unknown. But in the other 2 reports, there was no indication as to why the patient went into acute renal failure. There was nothing about dehydration or cardiac failure, anything like that. It was just acute renal failure. So the next thing to do is to search all of your reports for urinary tract disorders. Do you have some others of raised creatinine or some others? And actually, we couldn't find any other terms for abnormal renal function. But there were 2 reports of interstitial nephritis. 2 males, aged 59 and 72 years. 1 had symptoms suggesting renal failure, and omeprazole again was the sole suspect in both reports. Time to onset 8 months and 4 months, and these people had biopsies. Wasn't that wonderful? You so rarely see a biopsy. And 1 of them had interstitial nephritis and 1 had fibrosis, which was thought to be due to perhaps repeated attacks of this. 1 recovered with sequelae, 1 was unknown. So you might start to ask, well, was this the cause of the renal failure in the other reports? So the next step was to look at the literature. There was nothing in the product information, the SPCs, so we looked at the literature. There were some published case reports of interstitial nephritis and omeprazole since 1992. Did we have enough evidence? Well, maybe, but we decide if you looked in Vigibase as well at that time to the end of 1995, there were 15 reports, and that was more than was published, and they weren't the same reports as the published reports, or not all of them. And that combination was statistically prominent, reasonably strongly so, and the IC025, which was greater than 0. I think you'll learn a bit more about this tomorrow. And so if we look at this pictorially, what you see is that you start at this end and you have some reports, and the IC value, which shows it's statistically prominent, is above 0, but it has a wide credibility interval, which is like a confidence interval, and that's below 0. The next year it's going up a bit, but it's still not statistically prominent. And then the following year in 95, you see that with those 15 reports, the lower border has gone above 0, and you have this IC value of 2.17, which is reasonably strong. So when you're doing a search, it's really important to find all the reports for the drug of interest. So search for the drug as a substance. You've seen this last week, I'm just reinforcing it. View all the ATC group. Ensure you find all the reports of the diagnosis. Some people might have just put in nephritis. So have a look inside the reports to see if it's interstitial nephritis. But be careful not to include things you don't want. If it's glomerulonephritis, that's different, and you don't want to include those. So learning how to search is quite important. So if we look at these Vigibase reports, there were 15 from 7 countries. There were 5 males and 9 females. The age range was elderly, or towards the elderly. The indication was upper gastrointestinal disorders, so nothing that would particularly cause renal failure or interstitial nephritis. Other illnesses, we went through them all, and there was nothing relevant to interstitial nephritis. Omeprazole was the sole suspect medicine in 12 of the 15 reports. There wasn't a strong dose-response relationship. Time to onset ranged from 14 days to 42 months. Now, normally you don't exclude any reports, but in this case, one of the times to onset was -4 months. So I haven't included that one. They do go out to 42 months, which is a long time, but in fact, the mean and the median in particular time to onset was only 2.5 months. So what happened was that we only had information on time to onset for 10 patients. You must note that you never get all the information for every patient. So like we had dose for 14 out of 15 patients. We had time to onset for 10 patients, and 7 of those were within 1 to 7 months. So there's a little bit of consistency there in terms of time to onset, but there's also an outlier. What about concomitant or co-suspect drugs? We're looking at the drugs now. We were looking at, and there we had no consistent patterns suggesting an interaction. 4 patients were taking medicines, 5 medicines that can cause interstitial nephritis, but in 2 of those patients, omeprazole was stopped and they recovered while the other medicines were continued. And there were sometimes you might not have a past history, but you can work out from the medicines the patient's taking what they might have wrong with them. So we looked for concomitant medicines that suggested the patients might have renal disease, and we didn't find any. We also looked at the adverse reaction characteristics. So we've looked at the patients, we've looked at the drug, and there were some additional adverse reactions like fever and fatigue and acute renal failure. nausea, malaise, weight decrease, rigors, and anorexia. So some of those suggest renal failure, some of those suggest there might be an immune reaction going on. And then we look at outcomes. Half of them recovered, 1 recovered with sequelae. This was on stopping the medicine. 3 hadn't recovered, and 4 it wasn't known. We had 6 that recovered on D-challenge with no clear alternative explanation. I was a little bit in debate about 2 of them, so you can see sometimes we're not quite sure, but that's how I put that. We had biopsy evidence in 1, and for some reason one of our New Zealand reports wasn't entered, so there's actually another one with biopsy evidence. And there was supporting evidence from others, so that we start to see a picture. There isn't a strong amount of data on on why the diagnosis was made, but we are starting to see a picture. So if you look at the summary of that evidence and compare it with the Bradford Hill criteria, you do have the strength of association. You do have a consistent time to onset with most, but not all of them. We don't have any concomitant medicines or histories indicating interactions or conditions that could have been an alternative explanation, and omeprazole was the sole suspect in most reports, so that was specific. Over half of the patients had recovered or improved at the time of reporting, and that was a reasonable time to recovery, if you looked at that. And then reports came from 7 countries, which was consistency, and interstitial nephritis is a recognised typical adverse drug reaction. So, did the drug do it? Does omeprazole cause interstitial nephritis? Any opinions? Sorry? Oh, do we have a microphone? Here we are.
Most likely.
Most likely. Okay, any other opinions?
It seems so.
It seems so, yes. Well, I mean, we do have the benefit of hindsight, but in fact, building that up, you can see that you would have taken that very seriously if you'd seen it at that point in time, because you had your own reports and other evidence coming in. And it's also a good way of thinking about how we use Vigibase and Vigilize. So, did the drug do it? The answer is almost never yes. Definitely, as you've said, most likely. The logic is probabilistic. We weigh up all the factors and assess the probability or likelihood. And our question for you is, when you do the reports on your desk, is there any other way of explaining this set of data? Is there any other answer equally or more likely than cause and effect? In these reports, there was no clear alternative explanation apart from omeprazole for interstitial nephritis in most of the reports in this case series. I'll just give you one other example, and then we'll finish. In the second quarter of 2010, diltiazem, a calcium channel blocker, and rhabdomyolysis were statistically prominent in Vigibase, and there were 55 reports. Does diltiazem cause rhabdomyolysis? It certainly wasn't listed in product information at the time, and it had been a drug that had been used for some years. If we look at these case reports, you can see a common pattern. You can see that all of the patients were taking simvastatin. Some of them were taking other medicines as well. There was another pattern in the case reports too, but I'll just talk about this. We know that rhabdomyolysis is a severe myopathy and often fatal. It's a known dose-related reaction to simvastatin, as we saw earlier, but occurs very rarely at standard doses. The risk is increased with interacting medicines, increasing exposure to simvastatin through inhibition of CYP3A4. The report suggests that simvastatin was the cause of the rhabdomyolysis. So was diltiazem just an innocent bystander that is commonly prescribed with simvastatin? That's the question. Did diltiazem have anything to do with it? Doesn't look as if it caused the rhabdomyolysis, but did it have anything to do with it? Well, actually, diltiazem is a weak CYP3A4 inhibitor, and it's not thought, at that time, was not thought to interact to a clinically important extent at standard daily doses of simvastatin. But if you go back to the report and look at the doses, the standard dose of simvastatin was 20. But what happened is about that time was that cardiologists were finding that the lower your LDL cholesterol was, the better at reducing you were, as your LDL cholesterol lowered, you had a more and more decreased risk of myocardial infarction. And therefore, there was a real push to increase the doses of the statins. So these patients were actually taking higher doses of simvastatin than the standard. And at that point, the interaction with diltiazem, which is also taken as well as these, became important. And in New Zealand, it was the clinical pharmacology registrar in our main city who picked that up and alerted us to it. And we looked back and thought, that's really interesting, because we intensively monitored simvastatin. We'd been following it for some years. Suddenly, we were getting reports of rhabdomyolysis, and we'd never had any before. So we looked back, and our patients were on diltiazem. And as the doses that were normally used had increased, this interaction became important. Of course, gemfibrozole can also increase the risk. And also this one only took 5 milligrams daily. But why do you think they got rhabdomyolysis? Well, colchicine can cause it too, but also cyclosporin is a very strong CYP3A4 inhibitor. It's an immunosuppressant used in patients with transplants. So there was an alternative explanation for that one, which was probably not so much the diltiazem. But you can see by looking at other drugs and patterns that you might find that there isn't a signal for a causal association. But then you can think about not discarding it altogether and making sure it's not an interaction. I've said all that. So again, to ask our question, is there any other way of explaining this set of data? Evidence suggests that diltiazem didn't directly cause the rhabdomyolysis, but it occurred because there was a clinically relevant interaction with it when simvastatin was taken at greater than standard daily doses. So again, did the drug do it?